It's a clinical case of colorectal liver metastasis, and it's a case of a female, 64, with a previous history of resection of melanoma, cutaneous melanoma, previous history also, but many years before, of a breast carcinoma, rhinoplasty, appendectomy, and the more recent history begin in March 2017 with a pain, fatigue, and also some abnormalities of the liver function test. But you can see an increase in tumor markers, especially CEA, CA99, very, very high. But the CA15-3, a marker, as you know, of the breast carcinoma, was normal. And she underwent an abdominal CT scan, and you can see here the big involvement of all the liver and all the segments by multiple metastases. And here you have also an abnormality suggesting the possibility of a tumor of the transverse colon. And so this patient was managed outside Paul Brousse Hospital. And so my question first to you is, would you use a US guided biopsy in this type of patient? Because breast carcinoma before, melanoma and so on. In fact, I will respond that it's not our policy in such context to do it. Why? Because we do always an endoscopy, upper endoscopy, and colonoscopy as a staging of such type of patient. And if we find a tumor, it's not necessary to do a biopsy of the liver. Anyway, this was done outside. It showed adenocarcinoma, probably of colorectal origin, okay? And then, as you see, the colonoscopy confirmed that there was a neoplasia of the left colonic flexure, and the colon tumor biopsy demonstrate an adenocarcinoma. So this shows first message that the liver biopsy was not useful for this type of patient. We did also thoracic CT, and we see bilateral micronodule suggestive of also lung synchronous metastasis, as it was the case for the liver. And so, in summary, patient 64, previous history of breast cancer, recent diagnosis of left colonic cancer with synchronous bilobar liver and pulmonary metastasis. And my question to you is, how would you consider this patient? Resectable up front? I'm sure not, of course, but potentially resectable, definitely non-resectable, and in that case, what would you propose? I don't know if clearly upfront resectable, no, impossible. All the segments are involved. Potentially resectable, very frankly, I would say no, almost never. And so I would have classified this patient as a patient definitely non-resectable. And so chemotherapy, everybody would agree to do chemotherapy. And this was the initial staging of the tumor. The patient received what we may call a palliative chemotherapy with FOLFOX, then FOLFOXcetuximab between March and September. And the staging after 8 courses show really you have on the left the previous one, and on the right the new one, the new CT scan. And you can see a spectacular clearance of the tumor in the liver. Of course, remaining lesions still are there, but it is a very spectacular, I would say, response to chemotherapy. And so from that, on the left initially, we go to that. On the right, after chemo, from that, we go to that. And you can see that the tumor is predominant in the liver, in the left liver, sorry. And so this was MRI diffusion with a persistent, I would say, diffusion signal on the left part of the liver, one also in the right, but much less. And this was the PET CT, who show clearly here a lesion on the right, but a predominant disease on the left liver. And so, biologically, we observe at the same time normalization of the tumor markers, which were very elevated initially, a very good response to chemo, resists more than 50% size reduction, a disappearance of the pulmonary nodule, and persisting bilobar metabolic uptake predominant on left liver lesion. And so, what would you propose? Would you propose to what is, I would say, the classical attitude, to continue chemotherapy, provided that we have considered this patient as definitely non-resectable initially? Would you see any place for any surgery? Possibly some of you could have an opinion.
Well, René, thank you very much. Very nice case. I think that the question here is whether you should opt for a strategy of debulking surgery or continue chemotherapy. And I think we still don't have the right answer for this. For example, in our series, the patients where we did debulking have a 5-year survival of around 10%, which is close to chemotherapy. So I would consider this for debulking, but I would ask more a general question. What kind of evidence do we have now to say that this is better than just chemotherapy?
Mm-hmm. No, it's a good question. You really raise the real problem to try to solve in this type of patient.
René, if we consider that the development, the appearance and the development of the cancer is the result of a loss of the immunotherapy fight of the patient against the tumoral cell, when you show us the gain due to the chemotherapy, we may consider that continuing to improve the immunology of the patient by decreasing the remaining tumor in order to give more chance to the patient to fight against the cancer.
It's a good point, and to my knowledge, the medical oncologist does not confirm some of them could say when you decrease significantly the tumor load, the efficacy of chemotherapy could be better. But this is not shared by all the medical oncologists. So it is a debatable problem, I would say. But
what is at that time the role of the surgeon?
So I will continue my case, and you will see that, in fact, provided that 7 months after chemotherapy, we observe this very, very good response to chemo. We, in fact, propose in our tumor board meeting to try to do a debulking surgery for maximal tumor load reduction, in line with what you were saying. The rationale for that was the liver predominant disease with disappearance of lung mets, the excellent response to chemo, and also the fact that we have today a running pilot study with the hypothesis that debulking surgery may provide, with chemo, a benefit in survival. So we did a left hepatectomy by laparotomy, wedge resection of segments 6 and 8, also multiple radiofrequency, multiple electrocoagulation of subcapsular lesion in different segments. Here you have the image of the liver, which is not a so friendly liver, with multiple, it looked like a cirrhotic liver, with multiple lesion. Here you have the liver after the left hepatectomy and some wedge resection on the right, and also electrocoagulation. And the post-operative outcome was uneventful. The CT scan at day 6 show that the liver does not contain apparent tumor nodule, and the patient leaves the hospital at day 8. Here you have the specimen of the left hepatectomy with, of course, a lot of tumor. And at pathology, there were 17 tumoral nodules, in total complete pathological response with no tumor cell identified. Metastatic celiac lymph node, I have done also lymphadenectomy of the celiac and pedicular because we have a suspicion of pedicular lymph node. And it was an old metastatic lymph node, but also incomplete regression. Resection was R0 for all but one nodule. And in the non-tumoral liver, we have a SOS syndrome with steatofibrosis. Then I remind you that the tumor, the primary tumor, was inside. So the question arises, what to do? So we begin by doing post-op chemotherapy, FOLFIRI-Erbitux, no image of recurrence 2-3 months after, a normalization persistent of the tumor markers. And at colonoscopy, we did one in August 2018, another one 5-6 months after, disappearance of the initial tumor. And so the question arises at that time, should we remove, in view of the fact that we have a total, complete pathological response of the liver, of lymph node, it is probably the same for the primary tumor. And a big debate exists, should we resect or not? Finally, we have also a meeting with the colorectal surgeon, and we decide to do it. We decide to do the colectomy because we have had so much investment in this patient that, in fact, we did it. We did a transverse colectomy by laparotomy, and surprisingly, there was a microtumoral focus with 4 carcinomatous tube in the muscularis of the colon, no tumoral lymph node, PT2 and 0. And so this justified the decision we had to do the colectomy. And so in May 2020, more than 3 years after the initial diagnosis, everybody was happy because the patient was in good shape, no chemotherapy at all, disease-free, but this happiness was relatively short because, in fact, on the follow-up, a recurrence appeared with a single nodule in segment 5, 30 millimeter. This recurrence was a single, no other metastatic site, confirmed on liver MRI. Pre-op chemo or upfront surgery, we choose to do a chemo before in a way to have a more follow-up and to avoid emergence of new lesion and so on. In fact, the lesion continued to be single. She received 4 courses of FOLFOX, good response again, CEA at 6, and we decided to do a repeat hepatectomy in August 2020 by wedge resection, uneventful postoperative outcome. At pathology, it was an active tumor with a 45% active residual tumor. We didn't perform any adjuvant chemotherapy because she was refused by the patient because she was treated by 4 years with chemo. And routine follow-up every 4 months, no recurrence. And everybody was happy. But this happiness, unfortunately, was still short because recently, it was the last consultation 1 week ago, on the follow-up, routine follow-up, a liver recurrence was present with 6-7 nodules, only located in the liver, and we decided to reinitiate chemotherapy. So, in summary, this patient had a colonic adenocarcinoma with a synchronous liver and pulmonary metastasis, definitely non-resectable. Because of the excellent response to chemo, we went for debulking surgery with post-op chemo. She had a complete pathological response, but not a complete pathological response of the initial primary tumor, who contained, despite the pathological response in the 17 liver metastasis, a residual active tumor. She developed a single liver recurrence 3 years after, And now, 4.5 years after, a new recurrence with 5 to 6 nodules. So for me, the message from this case is that debulking surgery may bring, in very, very selected cases, benefit in survival when a very good response to chemo is observed. The resection of all the previous metastatic sites is absolutely mandatory, even in case of complete response of one site. But of course, these need a validation by a prospective study, which is still in process in our center, with 21 patients who have been included in such type of prospective study. Thank you for your attention.
René, I think that really I approve what you say. You know, sometimes the Red Sea open. Sometimes Lazarus is raising and walking. And, you know, often I say, if there is a chance to be optimistic for the patient, you must take the chance. And I support you, of course. At the end, it could be a failure, but you give to the patient, you know, 3 years and little more, and not finish. So why not? We must think about that, not be, oh, when we see the picture at the beginning, it's sure, you may say, oh, finish chemotherapy, and then, you know, as you know, the chemotherapy always stop. That means the death of the patient is the end. But in this case, I think for us it's a lesson of optimism.
Of course, we agree because this is our philosophy and it is the hypothesis we did. I don't know if our prospective study will confirm or not. I will speak on it tomorrow morning, I think, about debulking surgery. But what I would say in this type of patient is that finally we can say pathological complete response. The job has been done by chemo. But the evolution shows that finally this complete pathological response may miss some residual tumor anyway. And so, in my view, this demonstrates that surgery, in addition to very efficient chemotherapy, may bring something additional. I'm not saying that we will cure the patients. Such type of patient, I think, the vast majority of them could not be cured. But if we prolong the survival from I would say 3, 4, 5 years, it's a gain for the patient.
Oscar is also, I think we privilege the far end. So Oscar, what time is it for you?
Thank you, Pietro. Now it's 6:48 in the morning.
You were very brave and you deserve.
Well, thank you very much. I regret not to be with you. I miss you all. So, and thank you, Pietro, for giving me this opportunity to ask René, and congratulations, René, for the results. 2 questions. The first one, if this patient could be a potential candidate for liver transplantation, if chemotherapy doesn't work. And the other one is, what about immunotherapy in this patient? Have you checked MMR? Can you use some immunotherapy in this patient? Thank you very much.
Thank you, Oscar. To your first question, I would say it's not a candidate for transplantation because initially some lung metastases were present. And because of the presence of any extrahepatic metastasis, even very, very small, is, as you know, an absolute contraindication to liver transplantation. So this patient could not be a candidate. And with regard to the status of this patient, she was a MSS, so no MSI, which represents a very, very small proportion of this patient, only we can estimate to less than 8%. And so there is no rationale to do any immunotherapy in such type of patient, but I would say no rationale today, because we are learning more and more about the possibility of immunotherapy, even in some, I would say, not MSI patient, but presently not.
And so we have this discussion many times in our MDT meetings, whether we should proceed to surgery or not. And we know that the first general candidates are the ones that respond very well to chemotherapy. Do you see any other factors besides this one that may indicate a better survival? Because this might help to select the patients where we do this.
Sure. It's a very good question. And really, we have very rough tools today for making such type of selection, and the best one is indeed the good response to chemo. But molecular biology, I mean in very, very near future, will probably help us to try to determine if there is any indication to help the patient with additional surgery or not. Really, I think this will change in a near future our mode of selection of the patient, really.
As always, quite impressive images and clinical cases. Of course, surgery in this case is one line of chemotherapy, and it's very good for patients because less side effects at the end. My question was about intra-arterial chemotherapy. Do you think there's a place of intra-arterial chemotherapy in adjuvant setting after the debulking surgery?
Sure. It's a very,
as those are missing
yes.
metastases that will appear.
It's a very, very good question, and I think intra-arterial chemotherapy on an adjuvant setting may have a bigger efficacy than systemic chemotherapy. The point is that in this patient, the systemic chemotherapy was so efficient that there was no clear indication. But I fully agree with you. When we see a sort of, I would say, loss of effect of systemic chemotherapy and that we can provide such type of surgery, at that time, in such type of patient with losing effect of systemic, we should propose intra-arterial adjuvant chemotherapy to avoid the recurrence in the liver, of course.
Yeah, René, thank you very much. And I think it's very important for us to build it out of the box and test things in that way. So really thank you to go into this direction. This procedure is clearly not for every surgeon, it's not for every patient. I guess here you have a long consent, patient need to know where they go. It's very important. And also, I think as you mentioned, it's experimental. That means in country where you have fee-for-service, this is a side comment, that should not be done. I think you cannot go on this, operate 3 or 4 times, going with all this if you charge as a doctor the patient fee-for-service. And if it is on an experimental protocol, or at least something like that, then you're totally protected, and I think that's also where we will learn. So I know it's France is not an issue, little issue, I do not know, but in some country it is. And we have seen in my country, as a few members here, abuse of this kind of procedures, doing tumorectomy without any plan. Here there is a plan, there's a hypothesis. We try to learn, which make total sense. They need to be centralized between individual surgeon doing 5-6 vivisection a year, embarking this. This is clearly wrong. And this is also I think our mission to communicate this. Just as a comment.
Yes, sure. I fully agree with you. This should not be, I would say, a reason for making that all the surgeon may say now, I would say a not complete resection could have a role in all the patient. I fully agree with you. We should be very, very careful in the indication, in the centralization of the things and so on. Fully agree, fully agree.